Welcome to the Alzheimer's Disease Virtual Education Summit Series, presented by Albert Einstein College of Medicine of Yeshiva University at NeuroSeries Live. You are tuned into the live session called Evolving the Diagnosis of Alzheimer's Disease, Controversies and Implications with Dr. Jessica Zwirling. My name is Dr. Norman Relkin. I am director of the Weill Cornell Memory Disorders Program and an associate professor of neurology and neuroscience at the Weill Cornell Medical College in New York. I'm pleased to serve as chair for this important educational summit series. Today's session is a live interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime during the program through the box in the lower left-hand side of your screen. Now I'd like to introduce Dr. Zwirling, an assistant professor at the Sol Khoury Department of Neurology at the Albert Einstein College of Medicine in New York, and the director of the Clinical Neurology Program at the Einstein Aging Study. Welcome, Dr. Zwirling.
Thank you, Dr. Relkin. Today's topic will be involving the diagnosis of Alzheimer's disease. The learning objectives for today will be to understand the current and newly defined criteria in Alzheimer's disease and mild cognitive impairment in order to provide a rational approach for diagnosis. It's important to understand the role of biomarkers of Alzheimer's disease within this new current diagnostic criteria. This next slide shows some facts from the Alzheimer's Association from 2013. There are about 5.2 million individuals with Alzheimer's disease, 5 million of which are over the age of 65. Currently, there are 15.4 million family members and other unpaid caregivers that provide about 17.5 billion hours of care to people with Alzheimer's disease. Alzheimer's disease patients inflicted with Alzheimer's disease have about 4 to 8 years afflicted with the disease, and there's an average time of survival among people of 65 that have been reported up to 20 years. Alzheimer's disease is the 6th leading cause of death in the United States and the 5th leading cause of death of patients aged 65 and over. This next current graph discusses the prevalence of Alzheimer's disease through 2050. I'd like you to pay attention to the yellow. There are 13.8 individuals total in 2050 that will have the diagnosis of Alzheimer's disease. However, the bulk of those individuals will be over the age of 65. Why is it important to diagnose dementia at all? Early diagnosis may improve outcomes in patients that are at risk. It is important for early intervention is key when the burden of the disease is lower. We need to intervene before the changes at the brain level. Early intervention before the onset of symptoms may modify the clinical course of Alzheimer's disease and prevent neurologic damage. An early diagnosis permits decision-making and planning by the patient and the family to allow them to have enough time while the patient's capacities are still retained. There are some basic precepts that I'd like to go over. Cognitive impairment is not a normal part of aging. We frequently get questions of what does it mean when I've lost my keys or I can't find my glasses. Cognition does slow down with age. The speed of processing does slow down. The difficulty with multitasking can occur. Some new medical lexicon that is entered is a term called mild cognitive impairment, and this represents an earlier state of decline where patients have subjective complaints but functionally they remain independent. There are preclinical phases that have been defined prior to mild cognitive impairment that are now recognized that I'd like to review with you. The diagnosis and symptomatic stages involves recognition of different patterns of cognitive impairment. There's recognition of prodromal stages that need to be and may be assisted by addition of biomarkers and imaging. The new criteria and guidelines involve a new long prodromal phase of Alzheimer's disease. This pathologic process of Alzheimer's disease begins years and decades before the onset of symptoms. There's a critical concept that allows for preclinical interventions or disease-modifying therapy by identifying this prodromal phase of Alzheimer's disease before there's functional decline. We are able to identify therapies that may modify the course of the disease. In preclinical Alzheimer's disease, this is an asymptomatic period where the first brain lesions may develop but no symptoms. The correlate would be in heart disease for atherosclerosis by the development of plaques prior to the onset of a heart attack. There's also the prodromal Alzheimer's disease phase, or mild cognitive impairment due to Alzheimer's disease. Mild cognitive impairment in this category, again, symptoms, but they do not meet criteria for Alzheimer's disease. And then the third category, which is dementia due to Alzheimer's disease. This criteria was developed by Dr. Sperling and colleagues and represents Alzheimer's disease as a continuum with a preclinical Alzheimer's disease phase, a prodromal Alzheimer's disease phase equivalent to the new lexicon of mild cognitive impairment due to Alzheimer's disease, followed by dementia due to Alzheimer's disease. This graph shows this type of continuum, that there is disease progression. In the normal individual, there is no disease and no symptoms. In the pre-symptomatic phase, or the preclinical Alzheimer's disease, there's early brain changes, but there are no symptoms. In mild cognitive impairment or mild cognitive impairment due to Alzheimer's disease, there are brain changes and there are mild symptoms, but there is no functional decline reported by the patient or their informant. In Alzheimer's disease, we do see moderate to severe brain changes and there is moderate to severe impairment. A patient cannot function independently at this level. In preclinical Alzheimer's disease, there are some caveats I'd like to go over. There's no established link between the appearance of any specific biomarker in asymptomatic patients and the subsequent emergence of clinical symptoms. In other words, there's no one-to-one ratio. In early pathology, such as amyloid beta, it may be necessary but not sufficient to produce manifestations in Alzheimer's disease. These are caveats that I'd like to bring up, and I will show a slide that will show the interaction between genetics, environment, as well as biological mechanisms involved in the cascade and production of Alzheimer's disease. There are new guidelines to the mild cognitive impairment due to Alzheimer's disease. The diagnosis of mild cognitive impairment due to Alzheimer's disease requires clinical judgment. In mild cognitive impairment, there is evidence a patient comes with a concern about a change in his cognition over time. There are several domains that are tested, such as memory, executive functioning, attention, language, such as category fluency or naming different words that start with a particular letter, and visual spatial skills like clock drawing that have been impaired. The new lexicon of the DSM-5 criteria recognize that there is a restriction or a deficit of between the 3rd and 16th percentile in mild cognitive impairment. Again, in mild cognitive impairment, there's preservation of independence. They do not meet criteria for dementia. Again, there's no evidence of significant impairment in social and occupational functioning. The patient is still remaining functionally independent. What types of memory assessments do we do in the office in mild cognitive impairment? Impairment in episodic memory is most commonly seen in mild cognitive impairment. And that kind of cognitive impairment is known as amnestic MCI, or amnestic cognitive impairment. Impairment in some of the other domains that I mentioned, such as visual spatial skills or executive functioning, represents a form of non-amnestic MCI. Cognitive impairments that included in the battery of testing that when we assess patients include the free and cued selective reminding test, the California Verbal Learning Test, trail making test, Boston Learning, or logical memory. Again, these are validated instruments which are norms set for patients' age and education that allow us to stratify the degree of cognitive impairment in individuals. When a patient gets a diagnosis of mild cognitive impairment, what does this mean to our patients? If they fulfill criteria, and their symptoms are thought to be of a neurodegenerative process, we can tell them that, especially an amnestic MCI, that they may have a 10 to 15% risk per year of progressing from mild cognitive impairment to Alzheimer's disease. It offers potential for earlier therapeutic intervention before the onset of full symptoms and decline, and it potentially can modify the course of disease and improve outcomes. So we've identified a preclinical phase where we can target therapies before the decline occurs. The rate of progression of MCI to Alzheimer's disease, there's a lag between the pathophysiology and the emergence of clinical symptoms. And the transition points along